The word stands for human immunodeficiency virus. It's a virus, an infection, that is passed through sexual contact or blood exposure, and over a period of time it causes damage to the immune system, which can lead to an illness called AIDS. AIDS is the acquired immune deficiency syndrome. It's transmitted through fluids, sexual fluids, genital fluids, vaginal fluid or semen or blood. It's not transmitted through saliva or tears or sweat. So it's transmitted through exchange of genital fluids, particularly sex without condoms, particularly vaginal sex or anal sex. It's not easily transmitted through oral sex.
So obviously when HIV first started, we had no treatments, and we had very large wards full of people with HIV who unfortunately were dying, and there was very little we could do to help them. But the changes since then to where we are now, where someone can go on one tablet a day and control their HIV and live a relatively normal life, is just a dramatic change. And so people really do have to understand that HIV is a treatable illness. It's essentially a chronic disease, and we can manage it with very safe treatments that have very small numbers or no side effects, taking tablets once a day, and those treatments can reduce the virus in the blood to virtually zero, which then eliminates the chance of that person spreading HIV to someone else. And so treatment as prevention has really become an important mantra in HIV management. But for that to work, people need to be for the whole thing to work, people need to be tested.
It's been a pretty stable characteristic of HIV in the Aboriginal and Torres Strait Islander population. About 50% of the diagnoses in the Aboriginal and Torres Strait Islander population occur among gay men, and the other 50% occur among heterosexual people. So among heterosexually acquired HIV, about half and half are acquired through injecting drug use, and the other half are heterosexually acquired through heterosexual sex. And that is a really big difference, where non-Indigenous cases, about 80% are diagnosed among men who have sex with men. A very small proportion are diagnosed among people who inject drug, about 3 or 4% every year. And that's a really big difference. In the first, say, 25 years, we had a similar rate of diagnoses as the non-Aboriginal population. In the most recent 5-year period, unfortunately, we've gone the opposite way to non-Aboriginal population. Our rates have increased substantially, and at the same time rates are going down in the non-Indigenous population. That's a good news story for Australia overall in terms of rates going down in the non-Indigenous population, but for our population it's a very wrong story, and something we need to dramatically change quickly to stop it really escalating and spiralling out of control. Over the last 5 years, more and more of our diagnoses are occurring in regional areas and remote areas of Australia, and we never saw that in the first 25 years of HIV in the country. So the importance of remote clinicians, our job really is to really promote early diagnoses, regular testing of people who are living in remote areas, particularly when they're diagnosed with another STI, so that we can get on top of it, not only for the health of that person, if they are diagnosed with HIV, but to really prevent an outbreak escalating across regional and remote Australia. Guidelines clearly say regular STI and HIV testing for those at greatest risk, particularly gay men, but in the context of remote and regional areas where there are other extremely high rates of other STIs, it should be routine practice to at least offer HIV testing once a year, and it certainly should be routine to offer a HIV test soon after a positive STI test. We really are trying to encourage follow-up testing for HIV. Clinicians who are working in areas where injecting may be an issue, but injecting's a very underground activity, and so clinicians might not even recognise that injecting is occurring. Once we get to a certain prevalence level in communities, the risk is certainly escalated in terms of HIV risk, and so we need to get clinicians to think holistically about offering HIV testing to all of the different risk groups that exist in the Aboriginal population so far.
The more comfortable you are and the more comfortable you look, the more comfortable your patient will be. People want to be asked, so simply find the courage to test out asking once or twice on a couple of during a couple of consultations and see how it goes, and just practice. Practice in the mirror can be a way to do it. How to say, would you like an HIV test today? Have you thought about having an STI check today? Broadcast information. Aboriginal people at the moment in Australia have higher rates of STIs than any other group. It's really important that we test and treat. There's good treatment available. Would you like to have a test today? It's important that people know what they're being tested for and give consent to be tested for it. And it can be really reassuring for people to know that prognosis is so good now with treatment, that treatment itself is effective and prevents onward transmission. And those things can allow people to feel safe and comfortable to have a test, that having a test is not such a threatening or risky procedure for them. So one of the important things if you're not in a sexual health clinic when you're doing the test, if you're in a local health service, it's about opportunistic testing. Because there are no symptoms, it's important that we bring up the opportunity to test and screen people when they come in for some other reason. Sometimes it's useful just to broadcast information. Broadcasting information is a technique where you give information without specifically implying that your patient has a need for it, and then that gives them a respectful opportunity to decide themselves if they need a test.
We've still got a long way to go in terms of addressing stigma and discrimination in our population. And the more we can openly talk about HIV and frame it as a chronic disease and frame it as somebody who acquires HIV today will live as long as somebody without HIV if they're on treatment, the better off we'll be. There are plenty of people in communities who still believe that this is a condition that only affects gay men. And what we need to do is break those myths. We need to break those myths about people who are suffering because of HIV. We need to break those myths, and we need to really openly and treat our own mob, whether they've got HIV or not, the same as anybody else in our community. And it's a big job ahead, and we've been working on it, and we've still got a long way to go, but so is non-Aboriginal Australia.